This is Dr. Howard Strassler presenting the e-lecture on Anterior Aesthetic Restorations and Preparations, Module B, Class III Composite Resins. And keep in mind that there will be a review throughout this presentation that relates to all anterior and posterior bonded composite resin restorations. You have a patient that you've diagnosed with Class III caries, a Class III defective restoration, and you're going to be restoring that tooth. Before you start any of your treatment, you need to select the shade. You select the shade before application of the dental dam, before tooth preparation. You'll select the shade based upon the color of the area being restored. And keep in mind the composite's translucent and will have a chameleon effect to match the adjacent tooth shade. There are a variety of shade guides that we can use to select a composite, and many composite resins contain their own shade guide that's color matched to the composite shade. For the TPH3 that we're using in the clinic, there is a shade guide that we use for selecting the shade. That's available in the prep dispense area. We also have additional shade guides in the clinic to include the Aesthetics, Nano Hybrid, Micromatrix Hybrid shade guide, and the VitaPan Vita Original shade guide with the Vita shades. The definition for a Class III carious lesion is a smooth surface carious lesion on the proximal surfaces of anterior teeth where their progression is described from the outer border of the enamel to the DEJ and to the DEJ and to the dentin as two cones tip to base. The clinical appearance of the Class III carious lesion is typically in the enamel, especially if there's a cavitation, as a gray shadowing on the radiograph. If we transilluminate the tooth, we many times see a dark shadowing within the enamel that's penetrated to the DEJ. This is a dark colored caries, and in fact in some cases Class III caries is an ivory color and not as readily apparent on transillumination. Our preparation design can either be from a facial or a lingual approach, depending upon where the caries has initiated, and in many cases we're using a lingual approach to preserve the facial enamel for aesthetics. The burrs of choice are either a 330 burr, which is in the clinic 1.8 to 2 millimeters in length, or a 35 inverted cone burr. Whenever possible, we're trying to maintain the facial enamel, and so we'll use a lingual approach. Aesthetics is far superior using the tooth structure than the composite. Our outline form is determined by the extent of the caries or the removal of an existing defective composite restoration that's being replaced. Our initial penetration is with a 330 burr, where in this case we can see the caries has gone past the DEJ once we've penetrated the enamel with our initial preparation. We can continue our preparation with a 330 burr or a 35 inverted cone burr. We can remove caries with a number 2 round burr using a slow speed or spoon excavation depending upon the extent of the caries. If the caries is more facial than lingual, a facial access can be used for the preparation. For this case, a 35 inverted cone burr was used to prepare the facial. On the radiograph, we can see number 7 has caries that's extending to the DEJ. Using a 35 inverted cone burr, and we can see examples of the inverted cone burr in the lower right-hand side, we prepare the tooth. Our completed preparation extends to the gingival area, the apical area of the contact, removes the caries, and removes and creates our outline form. And this outline form and caries removal was done using a 35 inverted cone burr, initial penetration with a high speed with water spray. Our Final preparation or removal of caries was done with the 35 inverted cone using the electric handpiece running on slow speed at a torque of 75. The margins for the Class III preparation depend upon whether it's stress-bearing or non-stress-bearing. Since the majority of Class III preparations have a lingual approach, the lingual margins are stress-bearing areas for Class I and Class II occlusions. And so we don't want to bevel those areas, and we leave it at a right angle margin, because if we bevel, we leave a thin flange of composite that can fracture and function. And so our cavity design for Class IIIs in non-stress-bearing areas and for a lingual approach for a Class III, or a facial approach for a Class III, the facial margins are non-stress-bearing. We'll use an enamel bevel of half to 1 millimeter long, half the thickness of the enamel. The use of the enamel bevel is to allow us to have more retentive tooth structure available after etching to bond to, and also to establish an aesthetic blend of the composite resin on the facial surface, the aesthetic area of the restoration. If our Class III ends on a root surface, we're going to keep it at a right angle margin similar to what we do for Class Vs, and we have no bevel. In stress-bearing areas, the lingual surface of a Class III for Class I and Class II occlusions, once again there's no bevel. Enamel can be beveled on that facial surface with a finishing burr, a finishing diamond, a hand instrument, or a conventional burr that fits that circumstance without damaging the adjacent tooth. Here we see a case with a defective composite restoration Class III, a mesiolingual on number 10. I can get an explorer on the upper left-hand corner. We look at the facial. I can get an explorer into the gap of this margin. Also, the patient has a complaint that the composite's unesthetic because of its shading. When we remove the composite, the outline is going to be determined by the removal of the defective composite. And in almost all cases, the final outline form is larger in the removal of the defective composite than if we had placed the initial composite. And so it will get larger, and you can see how much more extensive the preparation became when we removed the composite on the facial. And so whenever possible, we use that lingual approach for the Class III to maintain that facial wall for aesthetics. Although if the caries is towards the facial and we need to compromise the facial in order to remove the caries, then we take a facial approach. Let's take a look at a clinical case. Number 10, distal lingual and mesiolingual. And in fact, number 10 has a temporary restoration on the mesiolingual, and on the distal lingual we have a carious lesion that's apparent on the radiograph and through transillumination. We do our transillumination, and this is that ivory colored caries we were talking about, and we can see a very slight shadowing during transillumination as we confirm our diagnosis. Before placement of the dam or tooth preparation, we select our shade based upon the color of the area. For this case, we use the Vita Shade Guide, verifying the shade by putting some composite on the tooth and light curing. The composite before light curing may not have an accurate color due to the CQ, the camphor-quinone photoinitiator, which is a yellow-orange in color. Once you cure composite, it bleaches out the camphor-quinone, leaving the shade that is desired. Our isolation is done with the application of a dental dam. Wedges are put mesial and distal to create rapid separation between the teeth to compensate for thickness of the matrix band, and also to protect the dental dam from being torn during preparation, and also protecting the adjacent teeth. The preparation will extend to break contact gingivally, and that's determined by the extent of the caries. It may or may not break contact facially. In this case, the mesiofacial did break contact. It may not break contact incisally. The extent of the caries and the preparation will be determined by the caries or the removal of a defective restoration. Beveling on the cavosurface margins. On the facial we bevel because it's a non-stress bearing area. We have no bevel on the lingual surface. We bevel using a rotary instrument, a thin diamond, or a thin finishing burr, or we can use a hand instrument, a hatchet or chisel, to bevel that enamel. On the lingual surface, we leave the cavosurface margin at right angles without a bevel. We're going to be bonding to the surfaces, and when we're bonding to the surfaces, we need to clean those surfaces before bonding. We're going to clean them thoroughly with interproximal gapped finishing strips to remove any stain or any pellicle. We're going to make sure there's no plaque on the tooth. We can use a prophylaxis brush or a prophylaxis cup using a slurry, a pumice paste of water. We'd get pumice from the lab, put it in a paper cup, add water, and then we would remove excess water using a cotton roll, leaving a thick viscous paste that we'd use to clean the surface. We don't need to be complacent. The tooth surfaces we're bonding to need to be cleaned so that we're bonding to clean enamel to optimize the adhesion, to optimize the seal at that marginal area. As with all our composites, we'll be etching the enamel and dentin. We'll be placing an adhesive, the adhesive that we decide to use, whether it be a 4th generation or 5th generation or a self-etching adhesive, and then the composite resin that we've placed. And the composites we use in the school are nano-hybrid composites. Our etchant will be a phosphoric acid etchant. And we're using a gel etchant, the blue-colored etchant, in the syringe, and we're applying it using needle tip dispensing. We're etching the tooth to clean the tooth surface, increase the surface energy, and to increase the surface area for the adhesion. The etched enamel surface has this microscopically roughened surface, similar looking like carpeting, that the resin will flow into and lock to that surface during light curing. For the dentin, we have a smear layer that's been created by the tooth preparation that's made up of loosely bound debris, collagen hydroxyapatite crystals. We'll be removing this with the etching process. The etching process removes the smear layer from the dentin, leaving on the lower right-hand side the peritubular dentin looking like a sponge and the open dentinal tubules. The enamel surface and the dentin are etched simultaneously. When we're etching these surfaces, the etch for enamel and dentin is 15 seconds for a simultaneous etch of both. And in this case, we're etching the enamel and dentin simultaneously for 15 seconds. We're then thoroughly rinsing the surface of the preparation and the tooth surface with an air water spray or a water stream for 10 seconds. We always etch beyond the cavosurface margins. The tooth is dried with an air spray. The enamel will have a frosty appearance, but the dentin shouldn't be dehydrated, and we should slightly moisten the dentin, leaving it with a glossy appearance with no visible water present. Note in this clinical image we can see the frosty appearance of the enamel surface. A mylar strip has been applied, and the smallest, thinnest wedge, the orange wedge, is in place. And these teeth are very close together. There's close root proximity, and even the thinnest wedge is difficult to get into place. We can use either a multi-bottle adhesive, a 4th generation adhesive, the Scotch-Bond multi-purpose with a separate primer and separate adhesive, or we can use the OptiBond Solo Plus. For direct composite restoration, we're typically using the OptiBond Solo Plus, a 5th generation adhesive for our restoration. As previously described, the chemistry of the adhesive for a fourth generation, the separate primer has an organic solvent and a hydrophilic monomer, HEMA, and the adhesive has a bis-GMA hydrophobic resin with the addition of a hydrophilic monomer, the HEMA, in the adhesive. For the fifth generation single component adhesive, the primer and the adhesive are all in one. An organic solvent, in the case of Optibond Solo Plus, alcohol, with the hydrophilic monomer, the HEMA, and a bis-GMA resin, plus a very small amount of water is present. The Scotch-Bond Multipurpose is our fourth generation adhesive. Our Optibond Solo Plus is our fifth generation adhesive. We're using the adhesive to seal the tooth restorative interface. We're decreasing leakage at the tooth restoration interface, and we're enhancing restoration retention by mechanical locking of the adhesive to the roughened surface. For the Optibond Solo Plus, with its unit dose dispensing, we never open the packet of the Optibond Solo Plus until we're ready to apply the adhesive. Opening the packet prematurely will cause the adhesive to lose its solvent prematurely, and the adhesive will not be optimized. On the right-hand side, you can see what the adhesive interface looks like, creating a hybrid zone with flow of the adhesive, resin infiltrating the dentinal tubules and the peritubular dentin. For this case, we applied a single component adhesive with a brush or a micro brush. The brush or micro brush has to fit into the cavity preparation. We rub it into the dentin surface and we let it sit in that surface for 5 seconds. We then use a gentle air stream to evaporate off the adhesive, evaporate the solvent and thin the adhesive layer, and then we light cure. Here we see the light on the lingual surface, light curing the adhesive with the presence of a mylar strip so we don't join the two adjacent teeth together. We light cure the facial for 10 seconds. We light cure the lingual for 10 seconds. The amount of time we light cure is based upon how close we are to the surface. The light is at right angles to the preparation. The light is as close to the tooth as possible. We're going to place the composite in our Class 3, and for most Class 3s, they're minimal sized restorations, and so we can place one increment to restore. We want to place composite in increments no greater than 2 millimeters to minimize polymerization shrinkage. In larger Class 3 preparations, as we can see in the lower right-hand side, we're actually applying 3 separate increments, light curing between each increment to control polymerization shrinkage. Our composite resin for this case is placed in 1 increment because it's less than 2 millimeters in depth. We syringe the composite resin into the tooth preparation. We remove all the excess before taking the mylar and adapting the mylar to the tooth surface. In this case, the distal lingual of tooth number 10, I'm squeezing the mylar strip and I'm stabilizing it using the cotton pliers, squeezing it up against the tooth. The wedge has been placed from the facial because it was difficult to get it in from the lingual due to root proximity. I hold the matrix securely, and the reason I hold it securely is the composite wants to stick to that mylar matrix, and we can end up with gaps between the restoration and the tooth preparation if the matrix is moving and not adapting the composite. I light cure using our blue wavelength light, which is between 460 and 480 nanometers. We're using a shield to protect our retina from the high-intensity blue light. It's positioned on the lingual surface and the facial surface 20 to 30 seconds. This is a composite resin. The darker the composite, the greater the curing time that we need, and hence the range depends upon the energy needs of the composite to fully cure it. Finishing the composite is universally the same. We use the instrument that's appropriate to the tooth surface being restored for its shape. We use the same sequence of finishing, going from coarser finishing to finer finishing. For composites, we start with finishing diamonds and finishing burrs, and for the Class 3, we'd use that egg-shaped finishing burr. We then move to rubberized abrasives, our enhanced finishers. We can use, for the Class 3, the bullet shape, the point shape. A cup shape is used for a Class 5. A disc shape can be used for a Class 4. We then can marginate using our Soflex discs, moving from a coarse to a medium grit. The enhanced polisher will actually give us better finishing, and the disc is excellent for marginating flat surfaces. We use these finishing Soflex discs dry, but we always wipe off the grit we leave on the surface with a damp cotton roll between each of the different grits of any finishing, so that we are ending up with using the finest finishing with either the super fine grit or a polishing paste. In this case, for a Class 3, we're using the super fine disc to polish the facial and on the lingual. We can use a prophylaxis cup using a composite finishing paste. For this case, we're shaping the lingual surface with the OS1 red stripe fine finishing burr. We then go to the point shape of the enhanced finisher, running it at least 10 to 12,000 RPMs. So on your electric handpiece, you'd switch to the 40 and run it up to 10 to 12. You do not want to use the enhanced running it on the slow speed at 4, because this is not a fast enough speed to use the finisher correctly. It's an egg-shaped finishing burr. You'll hear football shape, but if you're from Europe or from Latin America, football is soccer, and soccer is a round ball. I'll then remove any excess gingival composite using a gapped finishing strip, pulling the strip through but not removing the proximal contact. In many cases, our Class 3 does not extend to the incisal, and the proximal contact will be in tooth structure. To remove any excess composite or adhesive at the gingival margin, we can use a disposable Bard Parker scalpel around that gingival margin, being careful not to do a papillectomy at the same time. And so our finish of our composite goes from coarser to finer. We're using interproximal finishing strips. We're using Soflex discs and polishing paste. And here we're looking at the completed Class 3 preparations on number 7DL and number 7ML that have been restored. Notice that we've got an excellent shade match for this case. Let's look at another case that has the Class 1 and Class 3 composite resin preparation and restoration. We're replacing the lingual pit on number 7, number 10. And so when we take a look, we can see the amalgam, we can see the Class 3 caries. Our initial caries penetration with a 330 burr, high speed, and then the finishing of the preparation with the slow speed. We've completed the ML and we've removed the defective amalgam. We're using a self-etch adhesive in this case, mylar strips in place, and we're applying the self-etch adhesive, the 7th generation adhesive, based upon the manufacturer's instructions. Once again, we're air thinning the adhesive, but we do not rinse a self-cure adhesive. A self-cure adhesive is never rinsed off the tooth. It's only air thinned and light cured. Once again, we're squeezing the mylar strip using the cotton pliers, and we're light curing the adhesive for 10 to 20 seconds. The composite for 20 to 30 depending upon the shade. The whites at right angles, as close as possible to the composite resin surface, to the tooth preparation surface. Our finishing is once again using the OS1 football-shaped, egg-shaped finishing burr and our enhanced polishing point, running it at least 10 to 12,000 RPMs. We're into proximal finishing using a gapped finishing strip on the mesial, and on the lingual we only have to polish to the enhance. That leaves it small and smooth enough to pass the tongue test. You've been watching and listening to Anterior Aesthetic Preparations and Restorations for the Class III.